So thank you very much, Fulia, Dinka, and all the members of EDSA who are doing a very fantastic job during this pandemic, having Zoom and see you on the screen. So thank you very much. As some people here know that I am interested in sleep, disturbance in person with Down syndrome, but I am not an MD. I am just a scientist and a mother, but I'm still very interesting, and I found new things when I prepared this talk. So thank you very much, because when we do things for others, it's also for us. So bad sleep, I am going to give you a little introduction with 4 or 5 slides. Just I want to is it okay for the way I am speaking for the translators? Is it okay? I am not speaking too fast or too slow. Is it okay? No answer.
It's okay for
Oh,
me.
okay. Okay. So you know that when you have bad sleep, you have poor efficiency at school, at work, or in general day life. You may be depressed. You have the diverse manifestation about food, decrease of religiosity, gastrointestinal manifestation, migraines, and many pathological conditions such as hypertension, diabetes, and stroke. You can use resynchronization compounds, but I'm not going to speak about that because people with Down syndrome are not really concerned with chronobiotic compounds. How to study sleep in the general population and in Down syndrome population, because it's exactly the same. You give a questionnaire to the family and find out if it's okay or not for the sleep. And in 50% of the questionnaire who are filled by the family, the MD found that there is a problem, but in 50 others, there is no problem. Anyhow, the main problem is when your child or your adult a changed mood or is very tired during the day. That may mean that there is a problem with sleep. So there are 3 important photographs that you do: electroencephalogram, electromusculograph, and electrooculograph. And you also measure oxygen desaturation. Why? Because during sleep, your brain is working a lot for many things. And if you have not enough oxygen or glucose in your brain, it does not function properly. So that's a very nice, I found it today, so maybe the people did not have before. It's a way with the EEG, the EOG, ocular, and the CTG, and the EMG, the muscular, and you have all the capture. It's in French, but sometimes it's good to have some French. And you have here the respiration for the trunk, and the jambers, the tibia, and SaO2, the oxygen capture, which are very important. And also in your here in you have the CO2 desaturation. But I don't want to be too scientist. Sleep organization, the first hour, you have the SWS, slow wave sleep, which is also called non-rapid eye movement, relaxation of the muscle and on the eyes, decrease of the heart rate, blood pressure, and body temperature. That's you feel cool, and consolidate on that period. You have consolidation of acquired memory. The second hour, you have rapid eye movement sleep, also called paradoxal sleep. It depends. It's mostly in France that it's called paradoxal sleep, or in Europe, I don't know. Anyhow, I don't want, you can see again this diaporama. You have stabilization of the recent memory. The course of the night, you have alternative cycles of these 2 types of sleep: slow wave sleep and rapid eye movement. Usually it's around 80 minutes for each. Sleep organization, when you start, you have for 10 minutes, and then if you don't sleep after 10 minutes, and if you are tired, that means you are not going to sleep. Then you have 20 minutes of light sleep. You can be awake if a fever come in your apartment. A deep sleep, then 10 minutes, and then very deep sleep for around 60 minutes. And then the paradoxal sleep for 10 minutes. The first sleep is around 120 minutes, and the other is 80 minutes. If you take a nap during the afternoon, you will find out that after 80 minutes, 90 minutes, you are awake. Sleep abnormality in children, difficulty to go to bed, difficulty to fall asleep, frequent arousal. Tiredness in the morning is a very important sign. Sleepy during the day. Very young children under 1 year have not this type of cycles. The cycles is organized at 2 years, maybe 3 years old, maybe for young children with Down syndrome. Adult sleep, a good sleeper fall asleep within 8 minutes, that I told you, few arousal, and 20% of the paradoxal sleep. More than 25% in the general population suffer from sleep abnormality. Sleep abnormality in the general population is insomnia. I am not going to speak about that. OSA, obstructive sleep apnea, which is called also OSA syndrome. That's why there is a S at the end. 20 to 40%, more or less, mostly in aged person. Tendency to fall asleep, and consequence, risk of high blood pressure and heart attack, consequence in development and growth. It's known that the children who don't sleep well and who have OSA maybe have some delay problem of height, and that has not been reported a lot, but maybe it's one of the reasons. It's not. There is also central apnea. I am not going to speak about in the general population. It's less severe than the OSA. Also, you have this kind of disorder, sleep fragmentation, frequent arousal without apnea, frequent in the general population, and maybe also in the DS population. And I am not going to speak, but just to remember that there are other sleep disorder in the general population. The consequence of OSA is hypoxia. I told you previously that when you sleep, your brain is working a lot, is not sleepy, and it needs oxygen and it needs glucose. And if there is less oxygen, there is a damage to the brain and also maybe to the heart. There may be hypercarbemia, that means increase of carbon dioxide. That's why I told you it's recorded during the sleep or at the clinic. Cardiac problem, cardiopulmonary complication, hypertension. On cognitive level, it has been shown that there is decreased attention, decreased concentration, and decrease in memory abilities. And remember, one of the first slides I show you in the two phases of the non-REM and in the REM, the memory ability. You have lower mean verbal IQ, mostly verbal, and lower cognitive flexibility. That's in the general population. And you can imagine what is for the population with Down. There are also motor deficit, especially for finer motor skills. And you know that the person with uh, Down syndrome have difficulty in fine motor, difficulty to rest, hyperactivity, aggressivity. Sleep disorder in the population with DS. I am not going to say again what I just said for the general population, but just to tell you that it's known since a long time, but it's only since 15 years or mostly 15 years, that it has been really accepted as a real syndrome for people who's Down syndrome. It has been in 67 found in France, in Lyon, by Jouret, who gave the name of paradoxal sleep. It's in Silverman, Sally Schott, and for myself, I knew the problem when I came to Madrid to the international meeting when Sally Schott was speaking. And there are a lot of studies about OSA, sleep fragmentation, and sleep breathing abnormality, but I am going to say mostly about OSA. I remember, because I think that's worthwhile, 88, 87. Firstly, it helps to raise general awareness of the importance of OSA. Secondly, it shows that diagnostic may help for suspected obstructive disruption. Thirdly, it shows that the most recent positive attitude toward children with Down. And what Silverman said, no longer should we accept development delay or pulmonary hypertension as inevitable consequence of Down syndrome. Both may be secondary to obstructive sleep apnea, and treatment should improve the quality of life for children with Down syndrome. And I will show you it's also true for old people. That's in 91. It's 30 years ago. A very good study showing, I am not going to deep to go inside this diagram, this diapositive, but to see that 16 of the children who had overnight polysomnography, 45 have OSA, 4 at central, 60 at hypoventilation, 33 have desaturation of the oxygen. Polysomnograph improved in all 8 children who undergo tonsillectomy. I will speak about tonsillectomy in a minute, but the normal as is only 3. It is concluded that children with Down syndrome frequently have OSA with hypoxemia, hypoventilation. Obstructive sleep apnea is seen frequently in those children in whom it was not suspected. In fact, it's the same as the general population. You have many persons in the general population who are tired, who report to their doctor, I am tired, and the doctor don't think it may be because of apnea. How children sleep, that's an old UK study, just to show you, if you compare to control children from 4 to 12 years old and 2 groups of Down syndrome children, 4 to 12 and more, number of person, of course they are less, but you see time to go to sleep, it's almost the same, a little longer for DS person. Time of sleep is almost the same, a little longer for the teenager. Awake during night, maybe much maybe according to controls, and sleep deficit breathing, sleep deficit breathing, much more. And apnea is one of the sleep deficit breathing. So next one, it's a study in Grenoble, index of apnea, you see, it's more than 10-fold more than in the control. Incomplex index apnea, it's what we call hypoapnea, it's 4 times more than in control. Oxygen desaturation is a little less, sorry, and time of desaturation is much higher. Okay. The sleep apnea is recorded as apnea hypoapnea index. You have the mild, which is 5 to 15 apnea per hour, moderate, which is 15 to 30 apnea per hour, and severe, which is more than 30. Most children have moderate to severe. Sleep fragmentation, sleep abnormalities, it's what I told you. in person with DS, the paradoxal sleep, as called also rapid eye movement, is decreased, more with high mental retardation. So the less IQ the child has, the less is the PS. Undifferentiated sleep is increased, and oculomotor frequency is decreased. And this may have a very important correlation with their cognitive poor efficiency, as we can say, because there can be a very important discussion about that. Okay? Cause of air obstruction and OSA in person. And as you may know, we will say, oh, they have this, that's the cause. But we can't do anything. And what I want to show you is that we can do, yes, we can. General hypotonia, craniofacial morphology, midfacial mandibular hypoplasia, glossoptosis, that means that the tongue is big and it's protuberant, and sometimes it go in front. And macroglossia, small upper airway, small trachea caliber, lingual tonsil hypertrophy, adenotonsillar hypertrophy. That's why the first thing to do is to go to surgery for adenotonsillar, dentofacial dysharmonia. Obesity, I will show you. Endocrine, hyperleptinemia, insulin resistance, steroid and gonadal dysfunction. I will not go far on that topic. Inflammatory and demographic, increasing with age and increasing in male as in the general population. Okay, that's the airway anatomy, the mandibular hypoplasia, the lingual tonsil hypertrophy, the middle facial hypoplasia, the adenoid hypertrophy here, the glossoptosis hypotonia and relative macroglossia here, the tonsil hypertrophy, and the pharyngomalacia with hypotonia and hypopharyngeal collapse. And here, laryngomalacia and subglottal stenosis. I think that's a good way to figure out what is in the mouth or in the trachea of your person with Down syndrome. Screening with OSA in children, that's now a study in 40 from Australia. Children with Down syndrome had more severe OSA compared to the typical children, suggesting a relative reluctance by parents or doctor to investigate symptoms. Just to show you, 14 children are snoring, 34 had OSA, mild and moderate. Those with Down syndrome had a higher average of PCO2 during sleep, and these findings highlight the need for formal screening tools for OSA in children with Down syndrome to improve detection and the risk factor. More recent study, a study from UK, and 30% start respiratory support. That's they got hypoventilation during the night, and they got a good adherence. I will speak later for all kind of medical apparatus. And this is a study for obstructive sleep apnea, but with DS, sorry, from France, from Necker Hospital, from Professor Brigitte Fourou. In conclusion, that's a treatment with CPAP and NIV. I will tell you later on, but just to show you that in the two study, when there is a good adherence for the apparatus, there are good results. Upper airway surgery represents a first-line treatment, but has limited efficacy. CPAP or NIV represent a very effective therapeutic option. I will tell you what is CPAP and live in a very short minutes, just to show you a study from Professor Verhulst from Anvers. I tried to put some studies out of the States from Europe. Prevalence of OSA in obese children in the general population is between 10 and 60%. In children with Down syndrome, 30 to 100%. This is a chart from Brazil, from Berta Pelli, and that's non-DS in gray and DS in white. And you see in function of age, and you see around 18 in his study, there is a very high obesity, and it's again here, if you compare 10 to 12 to 13 age, and you compare, it's really it's the BMI, the index of uh, weight. And here is the female and male. In gray, it's female, and you see that mostly female are higher BMI than male. Obesity predisposed to OSA because it promotes excessive fat deposition under the mandible, in the neck, and in the tongue, and this might contribute to narrow the upper airway diameter, during sleep, and to increase the risk of obstruction. And that's very interesting, because there's a real question why overweight is related to sleep in DS population. So the fact that excessive fat deposition in the general population, and maybe of course in the DS population, which is deposit in the mandible, in the neck, and in the tongue, increase the risk. OSA and aging, because first I said I will speak about only young people with DS, and I found, but there is also the old one in the general population. But of course, in DS, older adults which are at risk for OSA are also at risk, as all risk factors observed in the general population become more prevalent in DS because of endocrine disorders, obesity, physical inactivation, premature aging, and Alzheimer's disease. OSAs might accelerate Alzheimer-like pathology in older adults with DS, who, as you know, are high risk for dementia in later life. In this older patient with DS and OSA, it is possible that the obstruction and the collapse events may increase with age due to the modification in pharyngeal anatomy, redistribution of body fat, and/or increased laxity of the pharyngeal muscular structure. So, in the DS population, when they get old, it's very important to investigate their sleep. Conclusion, just to show you, I could have put that in the first, but I thought it would be at the end. General population for OSA between 1 and 5. In the population with Down syndrome, 30 to 65%. And in adult, it's increased a little bit in the general population, and it's more even in the Down syndrome population, male and female. OSA in children induced 9 points. That's a very nice study which has been done to see if OSA in children who has only IQ but not DS would have a decrease in the IQ. And it's shown that the children with DS, but the people, sorry, the people with DS has a higher decrease in IQ than other person who has also OSA, but but not DS. A really aging problem OSA in adult. It is highly recommended of polysomnography for all children, and even earlier. There are two studies who have been done for children from 6 months old to 3 years old, and there is now a new study done in Necker Hospital in correlation with the Center of Le Jeune Institute. Biochemical and pharmacological aspects, I am not going to speak about that, but there are very few studies. I will just show you at the end of the talk 2 or 3 studies. Very therapeutical approaches, medical treatment, surgical specific equipment. Okay, so medical treatments look at the nasal obstruction of the person or the child, spray of a saline solution, spray of steroid on or antihistaminics, or especially during spring because of the pollen sensitivity. Pay attention, avoid the risk factor like tobacco. Body health, lose weight if necessary, as I show you. I will have convinced. Walking, swimming, and all kind of sports. Nutrition and sleep, it's not very well documented. Necessity for a good relaxation before sleep, and I think there are not enough good studies about what kind of relaxation exercise can be done for having a better sleep. Surgery, I told you about removing adenoids and tonsil. It's very good in the general population, but not as good in the population with DS. Only a third of them have succeed and don't have, after removal of adenoids and tonsil, will have OSA anymore. Dentition, it is very important to maintain the best position mandibulars. I don't know if you have been, but you know that the mandibular is forward. Early praxis is very important and not enough done. I will tell you at the end. Okay, effect of adenotonsillectomy. It's very important that people who know that there are in children with Down syndrome, not only the efficiency of the surgery is not very good, but in sometimes they had a postoperative complication requiring medical interventions, poor oral intake, bleeding, and postoperatively, patients with Down syndrome who got that surgery had a prolonged hospital stay. So they are associated. So pay attention. It should be done in a very good center. This information is imperative to drive further quality initiative, but also to have truly information and discussion to provide anticipating guidance to patients and caregivers who are considering this surgery. But because still 70% have benefits, and this can be raised if you have good surgery and pay attention to the complication. That's a study from Anvers just show you that after after that surgery, there is still polysomnography abnormal, so superior at 2, superior at 5, and what she suggests is CPAP, NIV, I will tell you, weight loss, anti-inflammatory treatment, and myofunctional therapy, muscular therapy. Mechanical treatment, apparatus with continuous positive pressure, CPAP, it's called CPAP, but also non-invasive ventilation, masticatory apparatus, neuromuscular electrical stimulation, and mandibular advancement. So that is the mask, the complete mask, which go on the nose and take everything, and that the CPAP, and there's lack of motivation, side effects. The side effect is mostly skin irritation and also abnormal discomfort, appearance of gastrointestinal reflux, and sometimes, mostly, not many, pneumothorax. Always use the minimal efficiency pressure to avoid this. And parents should be informed about the potential side effect or complication. That's the different type nasal mask, facial mask, nasal cannula in the general population, and that's 3 months after treatment. You see facial mask is the best, but 8 months after treatment, still the nasal mask is the best. So the possible solution for interface side effects: skin iteration, don't tighten the interface, try other interface, facial deformity, nasal cannula, leaks, pay attention to the leaks. I will show you, this is not for you, but just I left it. I made the same simple nasal mask, oral nasal mask, nasal pillows just for the nose, the total face mask, the mouth piece, which is cannulas. That's the advantage. And this one has infant size. The other one have no infant size, but this one, which is the best, with no risk, is done only during the day and not during the night. The other one are all during the night, and they are in blue. I put in red the advantage in that column, and in blue the disadvantage: skin injury, mouth leaks, no infant size, mouth injury, mouth leaks, many risks, no infant size. The cannula, but it's not not many sleep. You need to know that type of things. Predictor of longitudinal alcoves. It's a Canada study with non-invasive ventilation, and I will go fast. Evaluation in this disorder, early detection of complication and barriers to NIV, initiation, and more family support. It's very good, but it's not enough well known, and it's not enough. There is not enough adhesion for the families. I found this, and I ask everyone in Europe to try that, because I find it very, very interesting. It's a Brazil study. It's already 3 years. Fabrication of a custom pediatric nasal mask for non-invasive ventilation using a maxillofacial elastomer. The facial mask, commercially available for NIV, for children with clinical conditions, are limited by size and hardness. I told you the disadvantage. The present report describes a straightforward method of a developing nasal mask from a room temperature vulcanizing silicone elastomer for daily contact with the nasal mucosa of babies during non-invasive positive pressure ventilation. The fabrication of the silicone mask with nasal tube is based on maxillofacial prosthesis technique with retention with steel prongs and elastics. And I think that should be really the gold tool. But protocol for trial with electromechanical, therapeutic, You have also neuromotion apparatus, mandibular advancement in the that's the 4-channel neuromuscular electrical stimulation equipment. This is the mastication apparatus, which is given. That's the mandibular advancement, oral appliance. The therapeutic effect on sleep parameters. It's on trial going on from Brazil again, but that's in the previous one is just the statement of what they think. This the neuromuscular electric stimulation will be undergone 3 times for 20 minutes session per week for 2 months. The mastication apparatus will be done 5 minutes, 6 times a day, with an interval of 2 hours between 2 months, for 2 months. And then the mandibular advancement oral appliance will be done for during the sleep for 2 months. That's the trial. We will see what's going on with the results. Okay, that's the next one. It's a very new one. It's hypoglossal nerve stimulation. Don't be afraid. The neurostimulator delivers electrical stimulating pulse to the hypoglossal nerve through the stimulation lead. You have the neurostimulator, the sensing lead. The sensing lead is going to the hypoglossal nerve. Here is the neurostimulator, and it goes in the fourth intercostal region, and it goes that, and you have nothing to do. But it's surgery. Okay, but the index for apnea hypopnea is very good. That's what is for therapy maintenance. For therapy maintenance. And here, after 1 year of treatment, if you remove the therapy, you still have a higher score of index. If you maintain the therapy, you have a good low apnea index, and it's the same for the index of oxygen desaturation. After 2 months, 12 months, it's very good, but if you remove, it's bad. If you still put on, it's good. So it's a good. There is a study, not a story, but it's a story too, in Cincinnati for this hypoglossal nerve stimulation in adolescent with DS. There were 7 female and 3 male, 16 years old in mean, from 13 to 17, BMI 24, and with a moderate index of OSA. The device was used around 9 hours, but it's very variable from individual, from 3 to 10 hours a day. Before implantation, you have the index of 24, as you see here, and after 2 months of the hypoglossal nerve stimulation, it's completely down with 3, which is very good. It induced a significant average reduction of the index, but unfortunately, there was a moderate yet significant clinical change in quality of life, QOL. But that's promising. Some biochemical study for OSA. I just show you a study from Split because Croatia is important. Atropine may be a marker for sleep obstructive apnea. Of course, if we could have markers, biochemical markers before we go to the clinic, sleep clinic would be very good. There is a very good study in coming from Austria with the metabolomics in sleep and insomnia and the sleep apnea. And there is also an Italian study from Rome who tried to find out biomarkers from the inhalation in the sleep breathing, and they found that 8-isoprostan may be a good informatic marker. But I did not find many, and I don't want to perturb. The last part will be, as I told you in the summary, OSA and COVID, that in the general population, and you see that aggregate data show risk for severe COVID illness include OSA patients may show heightened risk for COVID-19 complication. This is sleep apnea, a study from Helsinki in the general population. In contrast, among COVID-19 positive patients, OSA was associated with higher risk for hospitalization. Our findings are in line with early work suggesting OSA as an independent factor for severe COVID. That's OSA, COVID, male, BPCO, obesity, diabetes, hypertension that you have seen in the pandemia, and you see untreated OSA give you a higher risk, and when there is lower risk when the CPAP is with adequate adherence therapy is done, sleep quality, and you have lower risk. Thus, OSA is probably an important risk factor explaining the high mortality in the population with DS during the first episode of COVID-19 pandemia. I go to the conclusions. Search for sleep problems, early intervention, even if it's mild, especially in young children. Preference for non-aggressive intervention if possible, losing weight, relaxation, music. For mechanical intervention, try various with adhesion of the person with DS. It's very important, and her family. For surgical intervention, use a specialized center. Progress on the road for electromechanical device, but not yet on the Merkel. Progress should be better understanding OSA at the biochemical level. OSA is one of the main phenotypes for DS, which is now recognized. OSA is one of the risk factors for pandemia in the general population and probably for the population with DS during the first wave. Even if persons with DS are vaccinated, still use the barrier recommendation, mask, etc., especially for those who have not yet been treated with OSA. Pay attention to OSA for the population with DS if there is a new virus epidemic affecting lung inflammation. I am finished. Sorry to have been a little long.
Jean-Claude, thanks a lot. You gave us again so many information. Really, thanks a lot for all your presentation. Now we will try to look some questions and comments of parents or others. But I would like to start maybe first with the data, what you showed on the page 13 and 14. We have one question. Remember, that is how children with Down syndrome sleep. That is results from Southampton, from UK results, and also another from Grenoble. It's a question in these tables. Are there number of hours, or what exactly it is in these tables? Is that
Wait,
number of hours?
Can I go
it's
back
page
to
13 and 14.
Yes, how... Wait.
How children with Down syndrome
No,
sleep,
but I can't
and also
go.
study.
I can't go.
Oh, you can't come back. Yeah.
No.
Great. You no?
I remember. Voilà.
Yes.
I know.
Yes, great.
I know what she means. That's...
Yeah.
Yes.
No, not more. Okay. This Yes, this table and another
Yes.
table on another.
Yes.
Yes.
So what?
This is our number of hours. Is this number of hours, like example, time to go to sleep, time to sleep, awake during the night? This is
No,
this
no, no.
numbers
That's an
inside. What is
index.
that?
No, 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 no.
Index.
That's an
Okay.
index, of course, because they don't take 2 hours or 2 minutes. No, that's an index. I don't have the paper with me. That's an index. Okay, sorry.
It's
And
index. What is on?
in the other, that's the index of apnea, which I told you when a child, it's a male age 22. I know the story. I know who did that. It's Véronique Bricou in Grenoble. So the control did not have any arousal, and the DS had an apnea of 7, which is not very important because it's under 10.
Yeah.
And
Okay.
that
That means
is
it was.
hypoapnea. Here is hypoapnea. So it's incomplex apnea. And that is
Okay.
according to 100.
Okay.
Did I answer the questions?
I will see. Mr. Olivier, do you now it's okay with your question, with this explanation from Jacqueline? Please just write us, is that okay for you or not? Monica, could you help us with some other question? And Fulia, also please be ready. We have a several question in the Turkish, and that you help us in explanation. Monica, could you
Yes.
maybe, this is German and this is translated, but could you try?
Translations will be sorry, Monica. Translations will be done with will be done by translators. German translators can translate German questions, and Turkish translator can translate Turkish question.
Yes,
yeah.
German already translate, and we have a translation. Monica, please, could you from Hedy Frey best? Yeah.
There is a question, what do you recommend parents to do with a highly incompliant child for diagnostics and therapy?
Okay. What I would suggest is that the child, it depends the age of the child, of course, and it depends also of the way the sleep clinic doctor has presented the therapy. And I think it may take some time, maybe months, maybe, I don't know exactly, but that need to have a psychotherapy who would help the child or the young adult to understand. When a person understand that it would give benefit for him, so the thing is that maybe, and I don't know, but I am almost sure that there are some little movies made for helping children, young adults to be confident of that type of therapy. I don't know if the Canadian have done something, but that's for sure it should be done, because I saw, for another thing, I saw a little movie for children. It's from France, for the anesthesia in the hospital in I don't remember the town. It's in Angers, and they take the children. It's not in Angers. It's another town. They take the children to be so confident of anesthesia that it's the children who take their parents to go with them to the anesthesia. It's all a procedure, and maybe the MD don't have the right procedure. So I can find out if there is any little movie for that, but I think there should be, if I answer correctly to your question.
Yes,
And I understand that when you are afraid of a therapy, you don't adhere to the therapy. You are reluctant to that therapy.
There's another question. Thanks, Jacqueline. There's another question related with this. At what age do you recommend to start with the control? And how often should children go to control?
The control should, there is that very good study from Holland that start at 6 months old, I think. The earliest the essay of OSA should be done, it should be better for the child, for his quality of life, for the school, for a memory, for everything. So as far as now we find out that there are some device which will be good also for very young babies. I think, and I am not the only. If you ask the person in Anvers or the person in Belgium or the person in London or the person in Paris, they would tell you as soon as possible, because before 2 years old, there are so many things who are taking place in the brain of a child. And if the brain is not oxygenated enough when he is young, he may take delay and add delay to delay. But that should be done in a very specific place.
Okay, thanks. We have still another other questions. Which are the signs that the child is having disturbances in sleep? You already explained a little.
Yes, I have already explained. It depends the age of the child. If it's a baby, I really am not specialized, so I can't tell you, but I can ask what would be the sign for the mother. For the young one, from 2 or 3 years old till 10, is hyperactivity, sleepy, tired when he get from bed, and poor efficiency. But hyperactivity and tiredness when he awake is a sign that the sleep was not a recovery sleep.
Okay, we go to the next question. What about the additional administration of melatonin?
I had a slide for melatonin. I did not. I can't find out. You don't give medication before you know that this medication is needed, so you have a lack of this product, or it has been proved that this medication will be good. Myself, I try to raise a study, a real study on melatonin on children with DS. Why? Because it has been shown that for autism, melatonin, there was a lack of melatonin, and when they give melatonin, the efficiency, not of the behavior, but of the school and all this kind of efficiency was better. I could not do it in France, but if you could do somewhere in Europe, it should be done to see if children with DS have a lack of melatonin or not. I tried to raise that scientific study, but I could not do it. There are not enough epidemiological studies on the lack of certain things that may characterize. There is also something that I did not speak about, is oxidative stress due to overexpression of SOD, and oxidative stress is, in a certain sense, correlates with poor sleep, but that has not, there are 2-3 papers, but not many. And also with the animal models for Down syndrome, I was the first to make people looking at the sleep for this model, but now I have looked and there is no new things. There is one paper very good for one of the model of Down syndrome, but this model is not anymore the gold model. Did I answer your question?
I think so. There are some questions in Turkish. Fulya, could you please check?
I tried to translate, but if you, Fulya, maybe could do better from Eileen. If I understand well, that is a question about why our children are sleeping. They are turning around and sitting on the bed too much. Why they can't sleep? What they have?
Yeah.
Why can't sleep normally or deep sleep that they have?
Why why they are turning around during their sleep, and
because
why
they don't
do they sleep?
Because they don't find a good position. I have read something today that they should sleep with an inclination, with pillow, at least for 30 degrees, because the air does not pass properly when they are laying down normally. That's one thing. And the other thing is that you try, I've read that you try that your child does not go too much on the slide, but why they don't go to sleep? Don't go properly to sleep. It's because it's very hard for them, because they and that's why I told you about relaxation, because I think that should be really one of the things for young one that should be, and maybe not the mother, because that make it stress. The mother will go away, and I want if she stays, but they are not. It's in, this question is very interesting. I will ask in the Necker hospital, and every one of you can ask also in their own town, if they can, when they look at polysomnography for a child with DS, if they can record how he sleeps. Can he sleep properly? How many minutes? So you can have a record of your child before polysomnography, after polysomnography, and after they have a medical advice for training. But that, medical person look at medicine and don't look at behavior. But that's so much important.
Okay.
I think next question is a similar, Fulya, yeah, from Eileen.
It's about why the children with DS sleep on the floor. We see that a lot. They prefer sleeping on the floor, not on the bed. I think it is colder than bed. They prefer sleeping on cold places, over the cold places. And they say that, do you know why? And the other one is what kind of mattress and pillow should we prefer for them?
So if I hear, I don't know the flow problem, but maybe because maybe it's a question of what the flow is in their representation. I don't know, but looking regarding what you say, because I did not know it was not recorded, at least as I know, maybe the mattress the hardest, like the floor. Maybe if you have something and looking as with a tissue, a hard tissue, stiff tissue, looking at the I don't know.
Okay, and there's the last question in Turkish question. Do children with Down syndrome sleep less than typical developing children? Is there any research about it?
I would say I really can't answer properly to that, but I think they sleep less. I think, but there is not. As I know, but I will try to look if maybe it's written somewhere and I did not see. But that's a good question.
Thank you.
Fulya, that's more, I think, Turkish. Now we have all. Monica, we have a few again German. If also, did you ask Jacqueline all question in English as well, please?
Yes, there's a question in English. I have a child who is very active during the day, yet has several awakenings during the night. Could it be due to other factors, the ADHD, and not sleeping problems?
It may be. It may be, but that can't be said before having looking at the sleep problem. If there is no sleep problem, okay, you go back to HDAD, of course, but first, and the second also is the adenotonsillectomy. I don't know if he has or he has not, but I want to tell you a story about hyperactive children with DS. We wrote in the news from chromosome 21, I think it's 20 years ago. We had a family, and the first child was a child with Down syndrome. The second and the third one was completely without anything. The fourth one was a child with Down syndrome. The mother was older at that time. And the family said, okay, we have one, we know everything about Down syndrome. And the second one was hyperactive and not at all hypoactive. So hyperactive may be completely part of Down syndrome. As a child in the general population can be very calm, or the other one in the family can be hyperactive. It's the same for the DS, if I answer correctly for you. But sleep, check the sleep before.
Okay. We have
I would like to say something. It's very important to vaccinate.
Just to tell that he is not Jacqueline London,
No,
it's
it's
René
Jacob.
Jacob Wessling, a doctor. He did not change his name.
Yes.
I invite him because I know him from the meeting and from everything.
I'm not the double of Jacqueline. I would like to say something. It's very important to vaccinate people against COVID, but I think that it's very important to vaccinate people with DES against pneumococcus also, because pneumococcus can be very dangerous. It's very easy to vaccinate.
Thanks a lot.
And there
Monica
are
and Fulya, do we have some more questions what we didn't answer?
Yeah, I think what do you recommend parents to do with a highly incompetent child for diagnostic and therapy as well?
I did not hear one word. What you suggest for therapy I heard, and before for diagnosis?
What do you recommend parents to do with a highly incompetent child for diagnostics and therapy as well?
That's exactly what I answered previously. I think,
You already had
yes,
this question, yeah.
Yes.
Okay, sorry.
No, it's okay, but it's okay. A child is afraid when he does not see the advantage of a therapy, or when he does not see that compulsory is a therapy. So I can understand, and the more easy apparatus will be available for young children, the better appliance will be for their sleep problem. But I can understand that this mask, even in the general population, some people don't accept the mask. So we need really the device that will be according to each phase of a person with Down syndrome, as in the general population. That's why I put you that Brazilian stuff, because I think that's in a period that we go to the moon and to Mars and everything, and with all this kind of technology that we have, and using modeling mask would be really effective, I think.
Here's another question about the importance of alimentation for sleep.
Yes, so that I will learn for that person who asked the question, because there is nothing really which has been well controlled. You can have paper about this and this, but nothing has been really well controlled. But it's known that nutrition is something which has to do with overweight, of course, but it's also about DS. I know that some family with DS take a lot of medication, the free medication, this kind of thing. And that would be very nice if they can report if before these nutriments, which are natural nutriments, their child sleep better after having taken these nutriments. There is no report, and everybody is doing in his own something, and that could be very good if we in EDSA we could make a questionnaire about nutriments and sleep and weight, because we can learn, really we can learn from families, I think.
Yes, Monica.
Yes, there's another one. A mother asks, her son goes to bed and everything is okay, but he awakes after 3, 4, 5, or 6 hours, and there's no chance to get him to the bed to sleep again. Do you have any idea how to help?
Yes, I have an idea. Like in the general population, there are some big sleepers and low sleepers. And of course, you can think that your child who is in the group of low sleeper would be a genius because he has more time to do efficiency. Now, I am a little joking, but not too much. 6 hours may be enough for him. Like when a child does not eat much, it's enough for him. So it's not because we think, and I can understand that for the family, if they want to sleep more than after 2 o'clock in the morning, I can understand it's difficult for them. But maybe it's type of child. It does not need more than 6 hours. I don't know. What age is your child?
Yeah, it's not mentioned, I think, in this.
What?
Okay, could we maybe just one comment about this vaccination again, pneumococcus? Beate Stenbeck said that she did vaccination even twice, and sometimes this vaccination is not working very well for children with Down syndrome. Just information from her. Maybe, like you, Jacqueline, said, maybe it will be good to make some kind of the questionnaires that we see if the people who already vaccinated with pneumococcus, which results we have. Maybe it will be good for study.
That's a good remark. this person who answer is an MD. She has many cases, or she is a
No,
family?
it's just family. What I know is a family, but
maybe we don't know, and that's exactly what we try to do for COVID, also for vaccination. Maybe there are atypical children or person who don't answer properly to the vaccination. We don't know, but don't step from one case to the generality. If
no.
most of them may benefit from that vaccination, that would be good. And I think René wants to say something.
Yes,
Yes.
please. That's why I read.
I think that we have the same things with COVID, vaccination against COVID. There are some people, and I think that people with DS the same problem, that there are a defect of immunity. And in France, we are beginning to make a third vaccination for people against COVID. Some people with the immunity defects and people who are in dialysis will be receive a third dose of vaccination. So it can be the same problem with the vaccination against pneumococcus or other vaccination.
Yes, what Beate also add on this, it looks like they don't build enough antibodies. It's just what René said. That means that maybe now if we have a COVID, after our person with Down syndrome got vaccine, maybe we need to check how much antibodies they have.
Yes.
And after that to see, maybe it's good after first vaccine, after second vaccine is usually the two vaccines, only Johnson & Johnson, now it's just one, that we check for them how much antibodies they have. And from that, we see together with our MDs what we are going to do, maybe with another vaccine or some other suggestion.
There
Yes,
will be,
you're right, but I think that it's necessary to make a dose of humoral immunity and cellular immunity, because the cellular immunity is stronger.
we are, if I can add something which is out of the scope of sleep, in Necker Hospital, we are trying to find person with Down syndrome who have not been vaccinated already and who will be vaccinated very soon. If you have around you through EDSA some people like that, please refer to me, and the person in the Necker Hospital will take the relation with that hospital or that doctor, because it's very interesting to have a point zero before vaccination and after vaccination.
Okay, we have 5 minutes more. Monica, do we have some more questions, what we didn't answer? And Fulia, please.
Yes, there's one left. How reliable are sleep studies with very young children under 4?
As far as I saw, the studies in Anvers and the one in Canada with very young children, and I don't have the result. It's not finished in Paris. I think they are really reliable within the range of specificity of each one. But I think if that has been already done, and Professor Scottco from the States has done a lot of things, like on very young also. I think it's like a court. There may be variation, but it's enough, how you would say, informative, I think. I don't know. Is there anyone who can better than me answer? Maybe in the audience.
Thanks a lot, Jacqueline. I would like to say that maybe we are closing just 3 minutes. We have more. Please, Jacqueline, what you would like to say for the end of our presentation, and also Renee, if you would like to add something for us, for parents and others who are on this our meeting.
Yes, when I started to do that type of things, I thought only to children, and young adults. I forgot completely the grown-up and the adults and the age adults. I think that's very, very important. Also the adults. That's why I had a slide today, because when you get old and you have a Down syndrome, you don't do anything. So I think sleep and good health and good nutriments are also very important for old one. Our kids who are young, mine is not anymore young, she's an adult, but I just tell you, she has sleep problem and nobody knows what she has. So but it's not an apnea, it's another thing. So I think I would say at the end, thank you very, very much to have given me the opportunity to do that diaporama, because I learned a lot. I did not know there were so many things new from a couple of years, and we need more studies, and maybe there should be a European study for sleep problem in the population with Down syndrome.
Renee, thanks a lot, Jacqueline. Renee, would you like to say some words for us at the end as well?
No, thank you. I don't have anything to say more. Thank you very much.
Yeah. Thanks a lot to you. I really would like to say thanks to Jacqueline, because I know her for so many years, and she teaches a lot about sleep apnea, and still she say, oh, I don't know enough. Yeah, still I need to learn. That's really fantastic for me when I see scientific person would like to learn all the time, and to find always something what is good, not just for her and also for all of us. Now, please, Fulia, could you close our webinar for today?
Okay, thank you. I want to say thank you to our interpreters, our translators.
Yes.
We have 3 translators. One is from the English to Turkish, Nur, thank you. And the other 2, one is from German to English and English to German, Svetlana and Benita. They are our volunteer translators. Thanks a lot. And for all attendees and also panelists, if you have volunteer translators, you can communicate with ETSA and we can arrange the system for you, and in that way you can translate our webinars into your native language simultaneously.
I just want to apologize because I did not think to make that translated in French.
Okay,
so,
next time.
next time.
Next time.
But the president of Trisomy 21 France should have thought of it, that. He is from okay.
Yeah, thanks a lot once again. And let's see, next month again is the 3rd Wednesday in the month with a new topic. Okay, have a nice afternoon.
Be
and
safe.
Be safe and take care.
Thank you.
Thank you.